It's really a pleasure to be here. Sharmila, Anandasabapathy, and as Steve mentioned, I'm the Vice President and Senior Associate Dean of Global Programs at Baylor. I'm going to provide a little bit of a roadmap for where we're going over the next 15 or 16 minutes. I'd like to talk about BCM, or Baylor College of Medicine's Global Programs, our ongoing collaboration with Dassault Systèmes, and I'm going to provide 3 foundational pillars for our collaboration that cut across device development, drug development and liver toxicity, and also transitional precision medicine, sort of in the context of our learning health system. And then I'm going to leave you with sort of a call to action and a framework for potential collaboration with an eye towards global health and health equity. Now, this map and that arrow shows you my route to Paris from Houston. And you're probably looking at this and going, she needs a new travel agent. What were you doing via West Africa? I'm going to save that for the end of my presentation, and I'll explain all of that. But suffice it to say, it has to do with the 60 countries, these are coded by disease entity, where we have global programs in clinical care, education, and research worldwide. And I do research, I run our global programs, but I am a practicing gastroenterologist, a technical gastroenterologist, an endoscopist. And I spend a lot of my time doing procedures like this in an endoscopy unit in Houston, surrounded by a lot of complex equipment. And in this room, I would say around me, there's over $1 million of equipment. Now, this is probably not feasible for most parts of the world, and I'm not entirely sure it's sustainable for much of the developed world. And so one of the things that we really think about, that I really think about, is how do we bring what we know, what we do, to the rest of the world equitably? This is really the guiding principle for our global programs. And so we think in terms of leveraging technology, leveraging innovation, really to reduce health disparities and enhance diversity in clinical trials, in education, in clinical care. And this may amount to developing devices or technologies that are portable, off-grid, battery-operated, low cost, using AI to overcome issues of user expertise or lack of physicians in many regions, using digital tools for remote education and training for capacity development. This really gets to the core of our mission in our global programs. So we've had about a 2-year collaboration with DS, looking at initially some evolving projects in cardiology and space medicine, an initial look at global cancer clinical trials in Morocco, and we're more recently looking to establish a virtual human twin center of excellence in the Texas Medical Center in Houston. Now, I'll start with the first sort of foundational project, which is a device. So esophageal cancer is an increasingly rising cancer worldwide, and endoscopy, as it's shown in that unit, which you saw a photo of, is really not feasible for most parts of the world, including many where the disease is rising. So what we have here is a tethered capsule endoscope designed for imaging the esophagus, because you can control the tether and the speed, and it has advanced optical imaging on it, which can differentiate neoplasia from normal esophageal mucosa. This can be removed and reused, and most importantly, it has about less than $100 in parts. We can develop this for about $75, and it can be done battery operated in the field and unsedated. The patient can be awake, so you don't necessarily need a physician to perform the procedure. You can record the images and, if necessary, have a physician do the diagnosis, or we are looking at adding AI or computer-assisted diagnosis for delineation of abnormal areas as well. Now, the challenge with this, and where the twins play a role, is that the standard of care for device testing is typically an animal model. But here's the challenge. This is designed to be used in an awake human, which has active peristalsis, and any animal model requires the animal to be asleep with no peristalsis, because if it was awake, it would eat it, right? Be a big challenge. So what we did was we used the twin, simulated the geometry, the anatomy of the esophagus using cross-sectional CT, barium esophograms. You can see on the right what was done. And we used high-resolution manometry, effectively our pressure tracings looking at peristalsis in a wide range of individuals to simulate the movement of this capsule through a range of esophageal diseases. And so this was one application where we were able to either enhance the pathway to get this into initial clinical studies. Now, the liver. We've talked about the heart, the lung, a bit about the brain. I have to say, I think the liver is kind of the unsung hero of the human body. Can't live without it, have to treat it well. Critically important for drug development, often a cause of drug failure, including post-market withdrawal, right? And drug toxicity can be what we call idiosyncratic. It can be unpredictable. It is not always dose-related. And so understanding the liver, critically important to drug development, evaluation, clinical trials, and of course, even chemotherapy, cancer care. I mean, the list is endless. So we have an ongoing collaboration with Dassault and Long Island University under the leadership of Dr. Shirkawi, who's here today, to develop a model for the liver with the goal of evaluating drug toxicity, starting with something as simple and as common as acetaminophen toxicity. So again, a critical, important step in development of the virtual twins. And one key part of this is diversity in that data set so we can look at liver metabolism across a wide range of populations. Now, one of the advantages to being in Houston is that we have NASA, the Johnson Space Center, at our doorstep. And so another existing point of collaboration, because we do a lot of the medical work for the space program, is looking at prediction and monitoring of the effects of long-term space flight, right? Because we are going on the Mars mission. This is another potential point of collaboration, in addition to cardiac resynchronization therapy, which is basically a fourth project. Now, the fifth underlying dimension to this, which is so important, are the ethical and regulatory implications of use of these virtual twins across the spectrum in clinical care, education, as well as research. And so this is something that we are actively looking at as well. And as these projects evolve, it'll be an important part of what we are doing. Now, many of you who come from academic medicine know that we're all moving towards these learning health systems, right? This is the virtuous cycle of academic health centers where you get information from your patients, aggregate data. This data is used to basically develop models, improve patient care and pathways, and ultimately improve patient health as well as population health, combining very often genotypic and phenotypic information to create this sort of learning health system where we're learning from the patients that we're seeing and feeding it back into the system. I see the twins as playing a key role in this learning health system, and we are testing this in the context of esophageal cancer and the precursor lesion to it, which is a condition called Barrett's esophagus. And Barrett's is present in about 1.5% to 2% of the US population due to rising rates of reflux disease. So what we are doing here, literally developing multi-scale models with a combination of sort of the macro data, so CAT scans, endoscopy, and then microscopic data, including pathology and evaluation of the microbial taxa via sequencing, either 16S or whole genome sequencing, to create multi-scale models of normal reflux disease, precancer, Barrett's esophagus, and esophageal cancer. And these cohorts can be used potentially as predictive models for patients and used to develop novel drugs, therapies, and potentially dietary interventions in this population. So when I look at the pathway that we have for us, it kind of cuts across all of our mission lines, from education, clinical care, to research, and potentially even to technology translation and acceleration, development of novel devices and drugs, as you saw. And I see the educational components starting immediately with our learners in Texas, but expanding to our global community of learners and clinicians, which are worldwide in those 60 countries. And we hope to expand the collaboration from GI and liver and space medicine to orthotics and prosthesis, trauma, surgery, genomics. This will be a plan for the future. And ultimately, you can see the twin basically mirroring that learning health system, right? Where we take multi-scale biologic data, develop the twins, create personalized models for precision care, which will ultimately create population-based data and enhance population health, and I hope, global health. So this is sort of an exciting opportunity because we can take the twins for innovation and development, perform cloud-based clinical research, ideally from diverse populations, and leverage these tools for remote medical education and training, where I hope it is needed the most. And so with this, the goal is really to develop platforms for medical science, education, clinical care, and ultimately solutions that will impact healthcare worldwide, perhaps even galactically, in the areas that are needed the most. Now, why was I in West Africa? So you'll recognize this. This is Senegal, and the adjacent country, which is the Gambia, where we have active programs. And Baylor, about 8 years ago, when I first took over as head of their global programs, faced the Ebola epidemic. You may remember this. And we developed this expandable shipping container, which is a standard ISO container. It goes on our cargo ship, but it opens like an origami box into a 400 square foot clinic. The first 400 square foot clinic, with all the supplies inside it, was sent to Liberia. And this is a picture of the unit in Liberia. We had this idea of developing a much more advanced structure, an operating room for maternal health care in the area of the world that needed it the most, because every mother, every baby deserves a safe and happy delivery, right? And so we developed this, this footprint, which had 2 expandable containers, and a recovery room and an operating room, a vestibule. This was done with 3DS software. It worked beautifully when we deployed it, and I would say the only part that the model didn't tell us about were the goats that would take refuge under these units. And let me tell you, it was impossible to get them out, although we were eventually able to get the goats out. They were chewing through everything. And this shows you sort of a picture of those units and the operating room and recovery room inside them. These are designed for women's health and labor and delivery. And you can see they really look, despite being inside this expandable container, as good as any operating room I have seen in Houston. So really remarkable. And this is our team of colleagues in the Gambia performing the first C-section in that region in these units last week. And so this was a huge moment for us and just an incredible occasion. And I think the best part of this is that these units have Wi-Fi and GPS. They have the capability to perform remote education because we can stream procedures from it. Apologies. And we can actually work with them digitally to perform clinical research and evaluate outcomes and metrics in these units on site or from a distance. So it provides continuity and access, and also a way to facilitate education, training, and research across the world. And this is something critically important to us. We operate several sites around the world. This is another one of our sites in Malawi. But I think one of the things that's important to think about is that when we think about clinical research, when we think about our models, we have to think about diversity and we have to think about it globally, right? Because otherwise we're going to continue to develop drugs and devices for the parts of the world that have access to those resources, and we won't develop things for the areas of the world that don't. And if we learned anything else from the COVID epidemic, we are all in this together, and the world is very, very small. So thank you very much.
A little bit of a shift in focus. It's going to be a bit technical, but I hope at the end of this presentation you understand what we're working on and how it can be used for basically all the digital twins that we have in mind for the next 10 years of this project. So if we think of virtual human twins, I've been very active in developing virtual human twins of the heart, but actually quite interesting to see for me in the previous talk, there's also now more and more interest in the gastrointestinal tract, and this is something we have also been doing ourselves. So we have been developing a virtual twin of the esophagus a couple of years ago, so I don't think you can have a faster response to a call for action, and I'm very happy to discuss those aspects as well. But just in general, if we think of virtual human twins of an organ, we see them as engineering tools set to transform research, diagnosis, and treatment therapies. But how do we develop them? So if we think of virtual human twins of any organ, the recipe is always the same. There's physics that we have to solve, there's boundary conditions that we have to apply, there's constitutive laws that we have to select and calibrate, and there's the geometry. And so that we bring together in finite element analysis, and that allows us to model the heart as nicely as shown here. However, how do you choose the constitutive law? What material model is valid for the tissue you're studying? That's not always easy to decide or to know, and especially for new users or new people coming into the community, this is not an easy choice to make. So if we think of constitutive modeling of soft tissue, how would you learn even a constitutive law? So what we typically tend to do in the field of soft tissue mechanics is that we deform a little sample of tissue, we measure the forces, and we assign a priori a certain material model. And so we're going to select that constitutive model and fit the constitutive material properties so that we eventually have a good match between the ones that we predict with our material model and the ones we measure. However, which material model will you select? What you can see on this slide is basically the history of myocardial constitutive models over the past 40 years or something. So basically every 3 years, especially if we look at the last decade, a new model is being introduced. But which model do you select? And if you select one, is it the best choice? That's not easy to know. And beyond that, implementing these material models is also not always that straightforward and is very prone to human error. So what we wanted to do in our work is, can we turn that paradigm a little bit around? Can we actually combine both the deformations that we put on our sample and the forces we measure, and automatically discover both the material model and calibrate the parameters at the same time? So easy peasy, lemon squeezy, right? I mean, this is something you can easily do with a neural network. It's a universal function approximator. You just have to have a relationship between the formation on the one hand and the forces on the other hand. Well, it's not that easy, I would say, because if you do this in a very naive way, you're actually ignoring some physics. So if you don't have a lot of data, what you would see if you put like such a model in place and you try to learn this relationship is that it would start violating the physics. For example, we would have stress going down. Even when we're stretching tissue further, that's not normal behavior for those tissues. Secondly, what we also will have is non-interpretable models. So we will get very complex models with various features and terms being activated. So that means more parameters to identify, and that becomes very problematic. And then lastly, also very often they start to fail to extrapolate. So if we only have data to a certain point, what we see is that after that point, such a universal, simple neural network will not really show physical behavior. So we wanted to circumvent that, and we did that by developing constitutive neural networks. And we did that by hardwiring the physics into this kind of architecture that you see here. So we're going to change this architecture by incorporating all the knowledge we already have in the field. So we're going to merge data science with physics that we already know. So how do we do this? So rather than working with the stretch, we're going to work with strains and the invariance from the strains so that we can guarantee material objectivity, symmetry, and we can also incorporate incompressibility if that's something we want. So that's by working with these invariants, as you can see here. Rather than knowing learning the stress, which is a tensor, directly, we're going to learn the strain energy function and then derive from the strain energy function the stress tensor so that we can still obey the laws of thermodynamics. And then apart from that, we're going to be very smart in which activation functions we're going to allow this network to use so that we still have physical constraints to what we will actually expect for this relationship between the strain on the one hand and the stress on the other side. And then lastly, we want to make sure that this is polyconvex so that we have some easy way of working with that in our finite element analysis solvers. So we made this choice to have no interconnections between the different layers, but so only the connections you can see on this network here. And so then we put this to the test. So I started with the history of myocardial constitutive models. There's so many out there. Well, we wanted to learn directly from the data which one is the most appropriate and then actually start using that. So what we did is that we used the most recent data that we could find from Sommer et al. From 2015, in which small tissue cubes were taken from human heart samples, and biaxial tensile testing was done on those and triaxial shear testing. And so what we actually already know is that most of the models tend to work really well on triaxial shear testing data, but not necessarily on biaxial tensile testing data. And so what we did is that we developed this very general constitutive neural network, now also taking into account all the different kinds of anisotropy that we expect in these tissues, and basically have a combination of 2 to the power 32 model options. So that's quite a lot. And so you use this model and the data that we have, put it in there, and actually use data science approaches to discover which model works the best for this specific data. So rather than first proposing a model and then fitting parameters, doing this all over again and again for different kinds of model, we automate this process. And so what comes out of this is the following model, which is quite similar in some sense to the one we already are using in the field for myocardial tissue, although there are some nuanced differences, especially in the isotropic contribution to the material behavior. Then we didn't only do this for myocardial tissue, but we also did this for arterial tissue. So we took, again, tissue testing data, so biaxial tensile testing data from arterial tissue. We looked at both the media and the adventitia, and again, used a network that looks like this, here taking into account transverse isotropic behavior, which we expect for arterial tissue, and put that data into this constitutive neural network to learn the most appropriate material model. And that brought us for the adventitia to the following model, as you can see here. And this one is quite different from what we have always been using in the field. So the state-of-the-art model, or the model that most people use, is the Holtzapfel model, where you typically have an I4 anisotropic invariant and one neo-Hookean contribution. But here we saw that we needed more nonlinearity in the isotropic behavior of the tissue to describe it well with the data that we had. And we don't need an exponential term in the fourth invariant, but a quadratic term in the fifth invariant. And that worked way better for this data than the original model. And interestingly, for this specific network, which still had millions of options, we discovered the exact same single model for the media. So it's different tissue, but we still discover a similar model for another piece of the tissue. And this also shows the robustness of our approach into automatically discover these material models. And it's not in the slides, but we recently also started doing this for main pulmonary arteries with different samples. It's unpublished work still, but we discover exactly the same model again. So that's quite interesting to know. Okay, but then everything's solved, right? So we have the material model done, but there's still a challenge there, because if we discover new material models, our solvers need to be ready to incorporate them into the finite element analysis simulation you want to do. And so rather than relying again on the users to do that, which might be again prone to human error, we developed together with Dassault a universal material model subroutine that can actually bring all these millions and millions of models into one overarching material subroutine. And we incorporate that into Abacus. How does this work? So we start from the most general constitutive neural network architecture that we could think of. So this even goes beyond the richness or the variety of models that you can have for myocardial tissue. I did the calculation on this. That would be trillions of models that we can actually have with this. So that goes a little bit beyond my head. But it's possible. So we incorporated this network architecture in a material subroutine. What you have to define is the stress and the stiffness tensors. And so we automated this process. And in the end, the subroutine is a set of nested activation functions giving all these individual contributions that we pick up from the material model discovery to the strain energy function, stress tensor, and stiffness tensor. And to call that from your solver, the only thing you need to define is those functions or these features that you discovered. So you just need to provide your solver this parameter table that you can see here, and each line is just one of those constitutive neurons that was discovered to be important for describing your material model behavior. And so once we did that, so we could start turning this into actual simulations. So we tried it on the heart first. So you saw this newly discovered material model. You have those 4 terms. So that's 4 lines that you have to define in your parameter table. And then just that easily it's brought into Abacus. And you can start simulating, for example, what the inflation would do, or what the endocardial pressures would do to the geometry for 4 millimeters of mercury for the right ventricle, for example, and 8 millimeters of mercury for the left ventricle. And so that allows us to simulate what the stress in the tissue would be for this more realistic material model that fits the tissue testing data as well as possible. Similarly, for arteries, we discovered a very different material model. We also applied that here. So that's, again, 4 terms, just 4 lines you have to define in your input file of Abacus, and then you easily can bring that material model into the simulation of arteries. Here, again, we wanted to understand what are the stresses in the tissue during the cardiac cycle, for example, and the results of that can be seen here. Here you can see the importance of also having different models for the adventitia and the media, and how that leads to different stress patterns in those models. And one might ask, okay, why do we care? Well, in the end, what you want to have is the most appropriate and accurate prediction of your deformation of your organs and the stresses in there, because those stresses and deformations are often seen as biomarkers that will have an impact on the long-term evolution of those patients, for example. And so what I'm showing here on the top is like the classical Gasser-Ogden-Holtzapfel model that people tend to use, and which we can still find a fit for. The R-squared value of that fit is a bit lower than the one we have with our new material model. But what is important to notice here that is this is the same geometry, the same boundary conditions, the same pressures, just the material model is different, and there's a small difference in how much better the new one is, but you see important differences. If you really pay close attention, for example, to the aorta, you already see a different deformation pattern in how it bends out. There's different stress concentrations in different regions, but apart from the material model, everything else is the same. So that's an important key takeaway from the work we have done. So in conclusion, what we have done is that we have developed constitutive neural networks to automate material model selection and calibration. We have developed or discovered a novel material model for both myocardial tissue and arterial tissue, but we've actually also done this for various other tissues, brain tissue, valve tissue, skin tissue, and many more are coming as we speak. And we eventually also, together with Dassault, developed a universal material model subroutine to incorporate any of those possible material models you discover directly into your finite element analysis solver. And what I think is important about this work is that we try to provide new tools for anyone new to the community coming in, novel users, people that are not used to tensor algebra, for example, or continuum mechanics, to still use digital twins, develop digital twins. If you have a new tissue, for example, of a disease patient, you want to make a model of what that tissue behavior means in a full model. This is a pipeline for you to do this. And we really believe if we can democratize modeling, that will also broaden scientific discovery. And that's why we're very excited to share this kind of work with you today. So if you want to read up more about this, the papers are mentioned on the slides, but feel very free to talk to me during the break after this, or contact me nevertheless. Thank you.
My goal is to share with you not only notions of vision and the capacity that it gives for our lives, but also to talk to you about how it's taken away, how blindness occurs, and how we're trying to approach a better understanding of that and perhaps treatments. So the fundamental here is that some years ago, Dassault Systèmes and Harvard Medical School came together to begin this project. Initially, Phil Bouchard contacted me and then followed through a couple of years later, recontacted me, and it led to further discussions and to Stephen, I think, really having a vision of opportunity that enabled us to dig deeper, and I really appreciate that, Stephen. And Joe Baldwin, who's here, who's providing, yes, Joe, the tactical and strategic sort of guidance almost every day, certainly week by week, that has really helped to move this project forward, and it wouldn't have done so without your involvement, Joe. Thank you very much. So this is about vision, the power of vision, right? It enables our lives, it enriches our lives, it allows us to enjoy the aesthetic beauty of our lives. But blindness takes it away. And so we're focusing on forms of optic nerve blindness, the optic nerve being the only connection between the eye and the visual part of the brain. And two very important forms of optic nerve blindness are glaucoma, which affects more than 1% of the general population, as well as a condition called NION, or non-arteritic anterior ischemic optic neuropathy, NION. You might have heard July 3rd of this year, we released an article expressing concern that Ozempic and Wegovy cause NION. It was the first significant complication of the medicines. We did not seek to establish a cause and effect, but we raised an association. Again, emphasizing the importance of trying to understand this condition because these medicines have been so fantastic in so many ways for the population. But there's an imperative now to understand what might be happening there. So these are the two primary conditions. I want to share this with you. You may have this is released in the last month or so. It shows you what modern imaging can provide. This is a fly, the fly brain, showing 140,000 nerve cells and 50 million synapses throughout the body. Not only are they imaged, not only can you see those three-dimensionally, they've been parsed out in terms of their functional capability, right? This is what is possible nowadays with imaging. And of course, we can't do this with humans yet, although the Allen Institute is trying to do this for the human brain. So we talked about blindness occurring because of blood flow problems to the optic nerve. And when we step back and think about blood flow problems in the body, it's important to understand that if someone has a heart attack, almost always we can find a blocked blood vessel, an occluded blood vessel. We know why heart attacks occur. And if you have one heart attack, it's very likely you'll have another. With respect to stroke, we understand the mechanism for both large vessel strokes and small vessel strokes. In both cases, it is blockage of blood vessels. So we understand this. In the kidney, you can see on your right the column of red blood cells, and just next to it, a lumen. So the blood is filtered to create urine. We understand a fair amount about how that works. And in the lungs, how oxygen is delivered to the body. So what we don't really have a good understanding of is the dynamics of flow through ultra-small blood vessels, like those in the optic nerve. So this is another wonderful image, it's a couple of years old now, showing the blood vessels of a mouse eye. So you could see, at least in this particular preparation, you can see essentially all of the blood vessels in the mouse eye, including some very small near capillary blood vessels. So, you know, you see a sense of what we can potentially do in human. This is far beyond what we've achieved so far, but if we could have anatomy like this, we could develop a blood flow model with great accuracy. So one of the interesting things about the optic nerve is the eyes take the pictures of what we see, but the visual part of the brain is in the back of the head. You can see the stretch from your right all the way to the left, the full extent of the visual pathway. But the red circle highlights the optic nerve head, a zone that's only 5 or 6 millimeters in length. And this is the zone where blindness tends to occur. And we don't understand what those vulnerabilities are. Now, people have looked for a long time. The father of modern anatomy, 1543, first looked. Waddell, 1700. 1754, not very far from here, halfway between Cologne and Berlin, Haller identifies blood vessels. He, too, being an artist, makes woodcut prints, which I'll show you a little more later. Here, that's Zinn's prints. And here are the blood vessels that we're talking about. Right, they were imaged in detail in 1755. The peculiar thing is, what we have learned from this prior work and how we teach the field is mostly from images like this that have become iconic images. And it was very hard for me to realize just a few years ago, in fact, that none of these images are based upon true anatomy. They're artistic drawings because we've never had three-dimensional anatomy of the blood vessels behind the human eye. You can't see those with magnetic resonance angiography or CTA. You can't see them. So we make slides, sections, and look at them, and then have an artist draw them like this one, which I think is the best one available. Now, Drenush, do you mind standing just for a moment? An extraordinary research associate working with me. And I have been spending the last couple of years developing a technique, leveraging a technique known as light sheet fluorescent microscopy, which has never been applied to the human eye previously. So here, going into the lab, which is to say the lab where fresh cadavers are, by elevating the optic nerve head, which is that white structure, flipping the optic nerve head back, just beneath it is the ophthalmic artery. And that ophthalmic artery is what delivers blood to the entire orbit. Then I am able to cannulate that small ophthalmic artery and inject a dye into that artery, and then remove the entire eye socket, where we then prepare the tissue. So by removing some of the peripheral tissue, the back of the eye being at the top, you're just seeing a small section of the back of the eye, and that long length being the tissue in and around the optic nerve, which contains the critical blood vessels. By doing this and so-called clearing the tissue, you can use light sheet fluorescent microscopy to image the blood vessels. I've not shown these at a meeting outside of our institution previously, or at least once here in Paris as well. But what you're seeing here on your left, the red structure is the beginning of the ophthalmic artery where I injected the dye. The back of the eye is to your right. And what you're going to see are the blood vessels behind the human optic nerve. These are the vessels, particularly as they go toward your right, where they become smaller and begin to enter the optic nerve. These are the blood vessels that bring the blood to the nerve head, the regions that's particularly vulnerable. What you'll see here, though, is that the blood vessels kind of stop. We don't get quite to the optic nerve head. This was our first attempt to do this. We were very happy with this, but also realized we had to do more. This is our second success. By the way, the optic nerve here is that tube in the middle. It's bright red because it has natural autofluorescence. You'll hear more about that in a moment. But what you can see with our second attempt is a large number of these vessels going along the length of the optic nerve, right? And this time, again, as we move toward your right, you'll see many of those blood vessels now entering the optic nerve head and the back of the eye. In fact, probably 15 to 20 of these small vessels right at the optic nerve head. So we're capturing this anatomy now in a really extraordinary way, and this is toward the goal of being able to develop an ocular blood flow model. That's our longer range attempt. So this second successful sample, if we do more image processing, you can see an even greater level of detail, smaller blood vessels. Here we are exactly at the optic nerve here, the back of the eye now to your left, the optic nerve head right in the middle, and you can see these very, very small blood vessels entering the optic nerve head. This is the critical zone right there. So we're really getting close to what we want. Just recently, our third successful sample, and I'm showing you this not because it's showing you something fundamentally different, but rather to give you a sense that there's a general theme here of these blood vessels as they go along the length and then enter the optic nerve head. That gives us confidence that we should be able to develop a reasonable ocular blood flow model. Ultimately, the tissues need oxygen. And here's a histological section from Hiroka from 2012. The optic nerve is this structure here in the middle, and to your left, the dense tissue to the right is the meninges. But you can see these capillaries moving into the optic nerve head, delivering hemoglobin and oxygen to the optic nerve axons, which are in bundles. That's where the critical issues occur. Ultimately, we have to understand oxygen diffusion. Now, the real peculiar thing here on your left, we're looking at a human optic nerve that was injected with a latex. And then the soft tissue was dissolved. You're looking at the human optic nerve head. It is filled with blood vessels. A reasonable hypothesis would be that this is an area that would never suffer from difficulty with blood flow. But in fact, it's especially vulnerable to it. And here, Marie Darche, right here. Marie, do you please stand? So I'm at the Massachusetts Eye and Ear Infirmary, and here in Paris is the National Ophthalmology Hospital, Cancale, in the Institut de la Vision where Marie works. And we have now begun a collaboration because Marie has the world's best images shown here of the blood vessels around the human optic nerve head. These have never been seen before. These are the ones we had the most difficulty imaging in Boston. We got all the ones on the outside. Marie's specialty is at the optic nerve head. So we quickly understood that we had to come together. And this is her most recent image of these blood vessels behind the, this is the optic nerve head, the blood vessels around the nerve head. We still have to work toward those vessels as they go into the nerve. That's our next step. But the point is we've developed these anatomical techniques to image the blood vessels along the optic nerve and then as they enter the optic nerve head. Years ago, people used ultrasound to say, what is the performance of delivery of blood to the eye? And here you can see in red that structure coming right up the middle is the, I can't go back, but you saw the pulsations. You're able to image these with ultrasound, and you could determine the velocity and the pulse by way of using ultrasound. The virtual twin in science, throughout the body, the goal of Dassault Systèmes is to be able to understand disease by modeling the normal organs of the body, then trying to understand disease and develop treatment. For this particular virtual eye project, Salwa Anam, who's unfortunately not here, Tien Kamangulu, and then Ashley Masterson, right there. And she'll speak with us in just a moment. They have been our engineering team led by the direction of Joe Baldwin. And here we're, it's the general flow that the initial step was to develop a finite element analysis model, but our goal is to develop a fluid simulation model. I'll begin just by saying that using the CATIA tools, we're able to take blood vessels from humans. We have images of these, many of them. But we're developing an idealized ocular vascularization model. On your right, you're seeing the blood vessels of a human retina. And then with that, one can develop tools to look at flow. Here, the velocity of flow, you see the color change right in the middle. A model has to be grounded, right? It's easy to develop the model. You have to know that it's grounded to something that's real, is something that will be valuable medically. And we have tremendous amount of information about blood flow to these retinal blood vessels because, 50 times a day at my hospital, we inject dye into the arteries and the veins, and then look at the blood flow in the retinal vessels. So we know what the flow patterns are in the range of normals. And we have shown by this model, here she used 4 million hexahedrons, 40 microns on a face, and shows a blood flow velocity that is very similar to what we see. Of course, in like for the heart and the brain, the problem is when the dynamics become perturbed. And so there are mathematical ways of looking at changes in perfusion at bifurcations of vessels. That's our longer range goal. But for the moment here, we're looking at pressures. So this idealized model can allow us to look at pressure gradients and velocities. So there's a larger goal here. We want to develop an ocular blood flow model. I've already shown you this picture. And the initial approach to get toward a model was to use surface meshes. But our data so far, and I think you probably have picked up on this, it suffers from 2 reasons. The first example I gave you, the vessels were sort of incomplete. That's a problem in terms of developing a continuous blood flow model. And secondly, there's a fairly high signal-to-noise ratio, one that we're looking to improve. We have ideas about how to do that. But it compromised the approach of using surface meshes. So we now have a different approach, and would you like to take us through that, please?
I think you can hold on to that.
It's okay? All right,
Yes,
good.
but,
So, I need to go back, and how do I do that? Here we go. Yeah.
Cool. So yes, with working with Dr. Rizzo, we've actually been working on creating a system model of various splines that are connected together. And those splines aren't just a single spline that goes along. You can see there's a lot of branching to it. And with those branches comes a lot of complexity whenever you're trying to change that single spline into an actual 3D surface from that. Because whenever those 2 splines intersect, it becomes very complicated to make a surface at that junction. And so with this, we've actually been working with Dr. Rizzo on his basically a spreadsheet of data from the light sheet microscopy that has a connectivity map of 1 point to 2 different points, so point A to B and point A to also point C. And so we have that connectivity map as well as the diameters along the different splines, and we're wanting to work towards automating it so that we can read in thousands of different splines, how they're connected, as well as the diameters at each of those locations in order to automate this process a little bit more, being that the imaging is so rough. You can't just directly take the STL model of it and turn it into a surface. We have to go back to a beam approach to do that.
Great. I may have skipped over one slide here. Let me see. No, good. So it's coming up still. Thank you very much. So in our the second successful sample, we're working with a laboratory of imaging at Harvard College in Cambridge, and as well with a Chinese company that set up shop across from the Harvard laboratory that are developing light sheet fluorescent microscopes. And the Chinese company is working with us. I mean, they come to our office and ask what we need, and then they develop it and employ it for us. So they're also doing a lot of this image processing. And here you can see the second successful sample. You can see they're able to tone down and improve the signal-to-noise ratio. But the goal is to capture the data. Here are blood vessels that have been identified, and now they're manually tracing these vessels and then turning this into splines that can then be utilized to develop this ocular blood flow model. You can tell this is an evolution. I mean, this is almost a week-by-week development effort for us now. So the future direction. Well, this is a model that we want to be able to adjust the parameters for individual patients. Someone has a high hematocrit or a low hematocrit or a very high protein level, it's going to influence the blood flow in the eye. And we want to have a model that we can customize for individual patients. Ultimately, as shown on the bottom, it's about oxygen delivery. So one of our concepts, a founding concept that really has not been studied, I think this is a jewel in our approach, is that people have studied a lot about the mechanics, the ocular mechanics, motion of the eye. A couple of 100,000 times a day, the eye moves back and forth. We know how it stretches the tissue around the eye. No one has studied the effect of aging and ocular motion on blood vessels, which we think has a high probability of being relevant. One of our team members on my NIH grant is Ian Siegel at the University of Pittsburgh. And this is from monkey. He's also done some human, but he's made a model of oxygen diffusion into the optic nerve head. So we have an expert in our team who has worked in the interior of the eye with respect to oxygen delivery. That's ultimately our goal. We have to develop the ocular fluid model to show, predictably show, how blood gets to the optic nerve head. In the end, of course, understanding disease is one thing. We'd love to develop a treatment, and that's our long-range goal. Thank you very much. I'm very appreciative we've been able to work together.